So today we're going to have a discussion about medication omissions. I just want to start by saying, did you know that we have on average 1,000 medication omissions reported on Datex on average per year?
Wow, that's a lot.
It is, absolutely, which is why this topic is very relevant. Starting off with that, Marit, can you define what a medication omission is?
Well, for me, an omission of medications is defined when a clinically appropriate medicine is intended for a patient, but it's not provided. And this could be considered a medication error. However, there may be times when a medication is omitted and it's appropriate. So, for example, a patient who has capacity has every right to refuse medication. Or it might be that the nursing staff or midwifery staff intentionally omit the medication. So, for example, a patient's prescribed an ACE inhibitor, but the nurse or midwife recognises that the blood pressure, the systolic, is only 70 millimetres of mercury, and that's the correct action to take to omit that medication. What happens thereafter is that the documentation should reflect the actions and escalation that's been taken. So, however, as mentioned before, an omission can be classed as a medication error when the documentation hasn't been completed or signed. So the nursing midwife hasn't signed to say the medication's actually been administered. There's a blank box. Or when a supply of medicine has not been escalated. Or when a patient has been admitted and unintentionally their regular medications haven't been prescribed. It's so important for us as nurses and midwives to document and escalate the reason for omitting medication because of the impact it can have on a patient's condition, their length of stay in hospital, or particularly for time-critical medications.
It's great that you bring up time-critical medicines, and actually across this organisation there are quite a few medicines that we consider as time-critical. These include anticoagulants, insulins, Parkinson's medication, anti-epileptics, and antibiotics, to name a few. Of course, this list is not exhaustive, but I think I should take this opportunity to hand across to Sarah to talk a bit more about why it's so important to ensure antibiotics are given on time.
Antibiotics are absolutely a time-critical medication, specifically in the treatment of sepsis. A broad-spectrum IV antibiotic should be given within the first hour, the golden hour, of recognition of sepsis. Yeah. For every hour delay in administering that antibiotic is a 7.6% increased risk of death for that patient.
Wow.
Ongoing doses of antibiotics should also not be delayed or missed, because one dose of antibiotic won't cure an infection, and if you don't have an infection, you can't have sepsis. Once the source of the infection has been identified with blood cultures or urine or sputum specimen, then the antibiotic should be targeted to that specific infection. Remember, you should start smart and then focus. So the patient has to have the right antibiotic at the right dose for the right duration for every single patient. Antimicrobial stewardship is really important to the trust and to the patient as well. So we've seen an increased risk of C. diff recently in the trust, and this is possibly because of inappropriate antibiotic administration. So this can impact on the patient's clinical condition and their outcome and their hospital length of stay. If you need antibiotic guidance, it can be found on the Trust Nav, on the e-library or MicroGuide.
That's really rich to know, Sarah. Thank you for that. So, right, as we said at the start, very important. How can we prevent medication omissions from occurring?
So there's two main strategies really, two main categories that I'd put them in, and I'm thinking about in hours and out of hours. So in hours for me is Monday to Friday during normal working hours. But the key thing for me is communication about medications at shift changeover and ensuring that nurses and midwives are actually handing over their medication charts. It gives that registered nurse or midwife that opportunity at the end of the shift to make sure that they've signed to say they've administered medication, but it's also about creating or generating that conversation around medicines. So for example, I may have had to give an antibiotic like vancomycin late because I was waiting levels to come through, so that clearly needs to be communicated because it will impact the time of the next dose that it's due. Checking other drug trolleys in the clinical area is paramount because these days a number of patients are moved bed spaces throughout the shift, and so when I'm doing my medication round, actually looking not only in this drug trolley if the medication is in there, but going to check in the other trolleys as well. Checking the Omnicell cabinet goes without saying, and if it's a time critical medication, contacting the ward pharmacist or pharmacy technician who will support nursing midwifery teams in obtaining the medications as soon as possible. What should midwives and nurses do if there isn't a pharmacist or technician on the ward?
So if there isn't a ward pharmacist or a technician available at that moment in time, and there is a time critical medicine due for a patient, to prevent an omission, we'd recommend that you put together a non-stop order form, bring it down to pharmacy where we will absolutely prioritise it, wait for it to be dispensed and checked, take it up back to the ward to make sure that your patient does not miss a dose of that critical medicine.
Great, thank you. So out of hours, I'm thinking about weekends and nights. Making sure that we're all checking the Omni Explorer function on the Omnicell cabinet, so nurses and midwives can clearly identify exactly what medication they're searching for and the exact location where it is on a ward and obtain it that way. Or bleeping the hospital bleep holder or the hospital at night team, and they will go and look in the emergency out of hours Omnicell cabinet in the pharmacy department, or they can also contact the on-call pharmacist. However, I also think it's really important for us as nurses and midwives to ensure when medication is delivered to the clinical area that they are stored, ready to use straight away and not left lying around.
That's really great to know, right? So to summarise, we know that omissions can be either intentional, i.e. medicine is omitted because it's clinically appropriate to, or it can be considered as a medication error. And this is whereby the medicine may not have been prescribed unintentionally, might not have been administered, or might not have been supplied in a timely manner.
Yeah.
So some of the strategies that we can use to prevent a medicine error from happening, and specifically an omission, is to ensure that handovers are timely and medicines are a key part of that handover. That in hours, we're looking at our drug trolleys, communicating with our staff members, going to the Omnicells to see if it's in there. If it's out of hours, making sure that we're using Omni Explorer as a tool inbuilt to every Omnicell, contacting the bleep holder, and where required, contacting the on-call pharmacist. So I think to summarise, the key thing here is that every medicine matters. Think patient, think impact.